Hello, everyone. Thank you for joining us. My name is Erin Dean, and my colleagues, Dr. David Fipps, Dr. Shruti Mutalik, and Dr. Ambika Yadav, and I will be discussing the promise of vascularized composite allograft transplantation and life-changing innovations. So just as a background for vascularized composite allografts, or as we may call them VCA during this presentation, they're really defined as transplanted anatomical units composed of multiple tissue types transferred together from a donor to a recipient as a single functional unit with its own vascular supply. When we talk about different tissue types, this may include skin, muscle, bone, nerves, blood vessels, and mucosa. One of the defining features of a VCA is inclusion of several distinct tissue types, all of which are perfused by donor-derived blood vessels, necessitating surgical anastomosis to recipient vessels to restore circulation. And different from a solid organ transplant, which is largely a life-saving procedure, with VCAs, they're more for restoring form and function. Really, the purpose of them is to improve a recipient's quality of life. So similar to solid organ transplantation, pre-transplant psychiatric evaluations, we often cover the similar domains as far as reviewing a recipient's psychiatric history, substance use disorder history, looking at social history, medical adherence, decisional capacity for procedure, their social support, coping mechanisms, a therapeutic alliance with the transplant team, financial and/or lodging concerns. But you could see in the orange at the bottom, we also talk more in depth about other aspects of a patient's or recipient's health that we may not cover as in depth with solid organ transplantation, such as body image, media coverage, and unique ethical consideration. And I just included on the right different types of VCA transplantation that are more commonly done, such as limb, whether it be upper. In more cases, there have been more upper limb transplants done than lower, uterus, penis, trachea or larynx, face, and abdominal wall. So for a VCA transplant evaluation, we know that the psychiatric evaluation and follow-up care are crucial. That's similar to a solid organ transplant evaluation. But in what other ways does a VCA transplant differ than a solid organ transplant? Well, there's unique risk-benefit analysis, really because of the requirement for lifelong immunosuppression in a non-life-saving context, which is, again, similar to VCA compared to a solid organ transplant. Differing rejection rates. As we reviewed, VCA types can include organ transplants that involve skin, like face or limb. And we know the skin is highly immunogenic and increased with increased environmental exposure compared to solid organ transplants. There can be an intense recovery period for patients who undergo a VCA transplant, and this may include therapies that are more intensive, take a longer period of time to undergo compared to solid organ transplant recovery, and then tailored treatment protocols. So there's really this diversity of tissue types in VCA transplants that require sometimes creative immunosuppression strategies to appropriately manage. So moving on to the rest of our presentation, I will be talking about uterus transplant. Then I will be handing it off to Dr. Fipps, who will be reviewing face transplant, and then Dr. Mutalik, who will be talking about trachea transplant, and then finally Dr. Yadav covering hand transplant. So again, just to get started on uterus transplantation, to start, I have no disclosures. But just to review the objectives briefly, we're going to review the current indications for uterine transplantation. We're going to examine the typical evaluation process for uterine transplantation, as well as post-transplantation follow-up care, and then also discussing some of the unique medical, psychiatric, and ethical considerations that are associated with a uterine transplant compared to other organ transplant recipients. So when we talk about uterine transplant, which you may see abbreviated in these slides as UTX, it's really treatment for absolute uterine factor infertility, or AUFI, which affects 1 in 500 women of fertile age. And it's something that really came first at the beginning of the 2000s, but really has evolved more substantially over the last decade. What are some of the causes of absolute uterine factor infertility? We most commonly see it being caused by uterine absence, whether that be congenital or surgical, with one of the most common congenital causes being Meyer-Rokitansky-Kuster-Hauser syndrome. It can also be caused by uterine defect, whether that be functionally or structurally defected. As of 2022, there's been more than 100 worldwide uterine transplants performed, resulting in more than 70 live births. And we may sometimes see that the transplant is from a deceased donor, or sometimes can be from a live donor, and more often from a live donor, as we'll see. This is from the Organ Procurement and Transplantation Network, really showing at the top the number of transplants that were done in the United States from 2016 to 2022. You could see that throughout the years, it kind of varies depending on the year. But the bottom graph really showing that the more common reason for our diagnosis indicating a uterine transplant was congenital abnormalities. When we look at inclusion criteria and exclusion criteria for uterine transplant, focusing on the inclusion criteria first, they usually say that the recipient needs to meet criteria, as we said, for an absent or non-functional uterus, be of reproductive age female, and it designates that as being between 18 and 45 years old, with a sufficient number of good prognosis embryos, willing and able to undergo criteria of this study, including psychiatric and social work evaluation, being willing and able to undergo the process of a uterine transplant, which includes general anesthesia, in vitro fertilization, major gynecologic surgery, pregnancy with potential high-risk complications, undergoing a cesarean delivery, and then an eventual hysterectomy to remove the graft, as we'll talk more about. Willing and able to receive immunosuppressive medications, standard vaccinations, having social support, ability to sign informed consent, not currently using tobacco products, and then willing and able to follow infectious disease protocols and prophylaxis protocols. As you can imagine, on many of the exclusion criteria are somewhat of the opposite of the inclusion criteria. So age of 45 years or older, or being in poor reproductive status of the embryos, the recipient having a history of hypertension, diabetes, significant systemic illness, any serious abnormalities of the heart, liver, kidney, a hematologic condition or central nervous system abnormality, any medical diagnosis that's placing the person at high risk of a surgical complication based on the transplants team's review of the medical history, any use of tobacco products within 3 months before the study enrollment or evaluation, a history of HIV or any history of mycobacterial infection, treated or untreated, presence of active documented systemic infection or recent systemic infection within the past 3 months, active substance use disorder, anatomical abnormality which would make the pelvic transplantation surgery unlikely to be successful, having a BMI of higher than 30, a relative or absolute contraindication to immunosuppression, and then finally untreated hepatitis C or active hepatitis B viremia or a carrier state. So when we really look at the flow of how a transplant occurs, I should say uterine transplant occurs, it really starts with, of course, evaluation of the potential recipient, and then LD being a live donor. So if there's a directed live donor associated with that recipient, they're also going to go through an evaluation process at that time. Once the evaluation is complete, their case is brought to the independent multidisciplinary committee for approval. And once approval occurs, then the recipient will undergo in vitro fertilization or IVF. For those that do not have a live donor, of course, then, there's obviously fast screening of a deceased donor at the time of the transplant to be able to move forward with the transplant surgery. So once the transplant occurs, usually anywhere from 3 to 12 months after the uterus transplant, the embryo transfer will occur. And, our goal is that that will result in a pregnancy, which will be delivered by cesarean section. And then transplanted uterus is intended to be a temporary graft with the goal to enable a pregnancy and then to move on to parenthood. So after achieving this desired number of pregnancies, a hysterectomy is typically performed to eliminate the need for ongoing immunosuppression, which can pose significant health risks for patients. Sometimes a hysterectomy may be done if there's a graft-related complication, like rejection or infection or something like that as well. And then follow-up is recommended long-term for several years, not just for the recipient, but also for the live donor, if a live donor was involved, the recipient's partner, if a partner is involved, and then also the child that was born from the transplant. So when we look at psychiatric symptomatology associated with uterine transplant, anxiety is the most common symptom that's usually endorsed, which understandably is higher in recipients who experience graft failure or have unsuccessful pregnancy attempts. It can correlate also with higher anxiety levels in the partner of the recipient and also a live donor that usually, again, is directed, so has a relationship with the recipient. Infertility-related distress is understandably reported in the literature associated with cases of uterine transplant. Depressive symptoms are less commonly reported than anxiety, but still obviously part of some patients' presentations. They typically arise more post-transplant related to medical or surgical setbacks, graft failure, persistent childlessness. The literature recommends really close monitoring for any peripartum onset of depression that may occur as well. What's reassuring, though, is that long-term studies show that most recipients report stable psychological health, especially if the transplant did lead to a pregnancy and then long-term parenthood. Some more specific considerations for uterine transplant, things that we focus on more than we would in other transplant evaluations. We looked at partner stability more than we would in other types of transplant evaluations. We also look at the psychological fitness of not just the recipient's partner, but also the donor as well. When we do our donor evaluations, we really make sure that we talk about family planning a lot. We make sure that the donor really is sure that they are not planning on future pregnancies before they're going to donate their uterus. And then also gauging the recipient's thoughts about the removal of the transplanted organ, that this is really a temporary measure, not something that they'll have the rest of their life. I included some of the commonly used questionnaires we use in uterine transplant evaluations and follow-up. Specifically looking at quality of life, most of the programs that have done uterus transplants use the 36-item short form survey instrument, or the SF-36, or the psychological general well-being form. We also use them to assess marital relationships or partnership stability, and we usually use the dyadic adjustment scale for that. Adaptation to stressors and coping skills. The Connor-Davidson resilience scale has been used, as has the post-traumatic growth inventory scale and the Millen behavioral medicine diagnostic test. And then we also look at childlessness and how our patients cope with that. So we sometimes use the fertility quality of life questionnaire as well as the fertility problem inventory for that. As we talked a little bit about before, body image is something that we sometimes focus on more with VCA transplants. And in uterine transplants, we talk about self-image a lot. And after a transplant, of course, we talk about change in body, but we also talk about change sexuality and just change in self-perception. So when this has been studied in the literature, women sometimes report looking at change in self-perception, a feeling like they're finally like their peers or finally like their female friends growing up, where, that they didn't get to experience some of the same milestones that their friends did, and now they feel like they're more included. But other times they don't feel that way. So there's this mixed feeling of belonging. And then finally, a chance of hope is endorsed. So for a lot of these patients, they feel that, when they were told initially that they weren't going to be able to carry their own child, that was a devastating blow. They were told that they never thought that was a possibility. And now to find out that it could be a possibility really is very fulfilling for them. Body changing, of course, having a new organ implanted that they want to keep safe, as well as a pregnancy that they want to keep safe. But even before the embryo transfer, an adult in puberty, that's something that a lot of, I think, uterine transplant patients don't appreciate, is that, the average age of menarche, I should say the median age of menarche in the United States is between 12 and 13 years old. So to be experiencing that much later in life as an adult can be a tricky situation or challenging situation. And then, of course, after the transplant, it has after the patient has undergone a hysterectomy, going back to quote unquote me, or how I was before the transplant, can be a big adjustment. And then change in sexuality. So some women report a lack of desire, pain, physical barriers since the surgery that make their sexual lives sometimes challenging as well. When we look at complications from the uterine transplant, for live donors, specifically medical surgical complications, the most common are urinary tract complications, primarily hydronephrosis, hypotonic bladder, or ureteric fistulas. For recipients, 23%, almost 1/4, will experience early graft failure. You can see on the right that this was the post-transplant outcome counts among uterus transplant recipients through 2022. And most of them had a functioning graft, but you could see about 1/4 did experience graft failure. Another complication that could happen is vaginal stricture, which that can create problems for embryonic transfer, cervical biopsies that need to happen to rule out rejection, and then also contribute to sexual health concerns. For the children born of these pregnancies, there is a higher risk of premature birth, as well as higher risk of neonatal ICU admission as well. A lot of women will ask me during these evaluations, what about the transplant medications? Are they safe for me? Are they safe for the baby? We know the calcineurin inhibitors are safe to take throughout the pregnancy, as are corticosteroids, azathioprine. We know that mycophenolate is not safe for the baby, so that's something that should not be given during pregnancy. There's mixed evidence on mTOR inhibitors and Betalicept. It's really something that, some evidence shows that it is safe, some says it should be avoided, so really should be evaluated more on a case-by-case basis for each patient. When we talk more about ethical considerations to round up this conversation, when uterine transplants were first starting to really be considered something that was going to be done, the Montreal criteria was developed, which was really to try to set an ethical guideline and framework for programs that were going to be starting to perform uterine transplants. I don't want to go through this in detail, but it has an important point that I want to point out. So when you look at the left, the recipient part, it says, is a genetic female of reproductive age with no medical contraindications to transplant. This has now been considered controversial, with many people advocating for a revision of this because we want to promote inclusivity. Primarily the statement that says a genetic female, there's growing support to include transgender females as potential uterus transplant recipients to allow a greater sense of self, a greater sense of identity. There has been concern, though, that given the intention of the uterine transplant at the time being a temporary procedure with the intention for childbearing only, the risks of lifelong immunosuppression for a non-life-saving procedure would need to be seriously considered. So something that I think will develop more in the future as far as, more talks about the indications for uterine transplant could change moving forward. Lastly, to talk about a few more ethical considerations. So for informed consent, we only talk about usually the risk to the recipient in most transplant evaluations. But in this case, we also need to address risk to the fetus as well, or the neonate, that's going through this as well. We're also dealing with a vulnerable population. There's concerns that some recipients are so focused on the ultimate goal of becoming a parent and having a pregnancy that they can carry, they may not be fully appreciating the seriousness of some potential risks of the transplant carry. We're using assisted reproductive technologies in these transplant procedures. So things like in vitro fertilization, which have their own set of ethical dilemmas at times. So combining those with the ethical dilemmas of a transplant can become complicated, really necessitates long-term follow-up for recipients, but then again, also the children born from these procedures. We also want to talk about justice and access to this procedure. It's not a procedure that's covered by medical insurance worldwide, and there's some parts of the world that don't even allow surrogacy. It's not part of their normal availability as far as a resource for those who want to have a child. So we need to really look at resource allocation and also make sure that we're optimizing utilization of deceased donors for uterine transplant. As we said, oftentimes uterine transplant are from live donors than the directed donors, I should say. But this can create a tricky situation. Sometimes it may present pressure for favorable outcomes. If there are not favorable outcomes, or if there's a pregnancy loss, that can lead to guilt on the donor's part or tension in the relationship between the recipient and the donor, which can become complicated. And then again, as we talked about previously, broadening the indications for uterine transplant to transgender women wanting to match their body physically to their identity, as well as to recipients not born, quote unquote, genetically female for purpose of gestation. Wanted to include this very briefly. This is very available from our institution's uterine transplant program website. This is a young lady I had a pleasure of taking care of who was born with Meyer-Rokitansky-Kuster-Hauser syndrome and was approved for a uterine transplant through our program. She waited 1 year for her donor and ended up getting a deceased donor. And there's her beautiful baby who was born, who spent about a week in the NICU, but did beautifully. So really amazing, innovative procedure that we see a lot of really amazing things progressing from. So I'd like to thank you all for your time, and I will turn it over to Dr. Fipps, who is going to be talking about face transplantation.
Well, hello, everyone. My name is David Fipps. I'm a CL and addiction psychiatrist embedded in Mayo Clinic's Transplant Center, and I'll be discussing psychiatric considerations for face transplantation within this vascular composite allograft presentation series. I have no financial disclosures to disclose, and here are my learning objectives. First off, we're going to review the current status of the first 50 face transplants. We're going to discuss the international consensus regarding indications, patient assessment, and selection for face transplant. We're going to review mental health comorbidities common to face transplant. We're going to identify pertinent mental health assessment domains, inclusion criteria, and exclusion criteria for face transplant candidacy. And then we'll elaborate on short-term and long-term considerations for face transplant recipients. Now, to start off, one of the things that I want to acknowledge at the beginning here is that there have not been that many face transplants out there. And we always need to be considerate when we discuss details of cases because it's hard to maintain anonymity, especially when there have only been a handful of cases from your specific institution. So, at our transplant center, we will not speak about or publish clinical or personal details of our VCA patients unless the patient directly approved of the content before it was released, or we only discuss information that has already been approved and is available through the public domain, like press releases, published books, as we see here, peer-reviewed articles, etc. So you are going to see pictures, you're going to see videos, quotes, and specific story details in this presentation. However, all of this information is in the public domain and approved by our face transplant patients before it was published. I will also show a donor photo taken prior to his death, and though it is also in public domain, I will still partially censor part of the photo just out of respect for the family. So I want to give a quick basic foundational understanding of face transplant to set the groundwork for our discussion. In 2024, JAMA Surgery published a study about the first 50 face transplants across the globe. The majority of face transplant recipients were male, average of 35 years of age at transplant, and it's close to about 50-50 if the procedure included a full face transplant versus a partial face transplant. Most of the inciting injuries were from facial traumas, with the most common of those being ballistic injuries, such as gunshot wounds. A large portion of the pre-transplant inciting events were in the context of suicide attempts. And we know that there's a fairly high prevalence of depression, anxiety, alcohol use, opioid use, and cancer in this population. Unfortunately, 10 have already passed away, 3 of which passed within the first year. And one of these deaths was from a completed suicide. And as long as we're laying the foundation here, I wanted to include information from the international consensus statement surrounding face transplant indications, assessment, and selection from the American Journal of Transplantation. These indications on the left are not additive, aka you could be considered for a face transplant with any of these first 4 options singularly. And I think it makes sense that the surgeons place a lot of value on a standardized, multidisciplinary evaluation that places a large emphasis on mental health, expectation management, and social support, particularly because of how many of these inciting events are suicide attempts. And there are many pertinent comorbid mental health conditions as well that play a role in this process. And one of the things to acknowledge is that this journey to face transplant often comes after a long and arduous pathway of difficult facial reconstructive surgery attempts. This is a pre and post picture of our first face transplant recipient. And he went through many different reconstructive surgery attempts where they took skin flaps from his forearm and forehead and covered a graft from his rib cartilage to create a prosthetic nose. In addition, they used the prosthetic jaw implants and muscular grafts from his leg to try to make his facial muscles more animated and more functional. However, this still leaves the patient with a significant loss of functioning and not to mention poor quality of life. I really appreciated this quote from the book about our first face transplant recipient. Although he was glad to be alive, he was left with a disfigurement that was painfully obvious to him and the rest of the world. More than anything, he wanted to look and feel ordinary. He wanted to walk into a room and talk to people without anyone scrutinizing his face or asking him awkward questions. He wanted to cast away the clumsy prosthetic nose that required daily cleaning with a toothbrush. He wanted to eat like he used to. He wanted to swim. He wanted to kiss. Similarly, our second face transplant recipient required 58 reconstructive facial surgeries over 10 years prior to pursuing his face transplant. And when we look at walking through the face transplant and what it looks like, it replaces all or part of the face with donor tissue. And it's estimated that about 85% of this example needed to be replaced. And in this case, the donor tissue included part of the forehead, the upper and lower eyelids on the right side, the nose, the mouth, the upper and lower jaws, including the teeth, as well as all the skin, muscles, and nerves of the entire face and neck. And the most meticulous part of this surgery was reconnecting the many small nerves between the patient and donor to ensure function, like eating, blinking, and even smiling is restored. So, when we look at this from a mental health lens, we already mentioned there's a high prevalence of depression, anxiety, trauma, suicide attempts, and substance use disorders. But also, there's quite a bit of functional impairment associated with the significant facial trauma. This is a good quote from the book about our first face transplant that I thought was quite poignant. Many of the foods fell out of his mouth because of his missing teeth and difficulty with chewing. It was easy to choke on salads, nuts, hard candies. Eating became a strictly private act. He did not like to be watched. So one can understand how there may be a fairly high rate of social isolation. Quote, he did not think he would want to show his face around town. He's been afraid to look at himself. And this could almost be considered a phobic response to his own face, which comes from a quote from one of the psychiatrists who saw the patient after his initial suicide attempt. So one can understand how this would be linked to depression, anxiety, and poor self-esteem. And we know that those with facial disfigurement often have a low self-confidence and negative self-image. And many have likened this facial disfigurement to being a type of social death, requiring and resulting in a deep grief for what was lost. And so this brings us to some of the parameters of how we would approach the psychiatric evaluation of a patient who is being considered for face transplant. I included the recommended assessment domains for all individuals being considered for VCA transplant on the left here. And then on the right, I added some additional assessment domains that would pertain to an individual pursuing a face transplant specifically. And I put this information here in great detail for your perusal later if you want to take a deeper dive into the handouts or to pause the video on your own to read these. Similarly, there have been proposed inclusion and exclusion criteria for face transplantation, which I believe you will find is conceptually fairly straightforward. As I'm sure you all know, transplant candidacy selection is not blindly based on checkbox inclusion and exclusion criteria. Rather, it's a clinical evaluation with a team-based decision surrounding the level of risk for a patient and asking, how can we best help mitigate that risk to make a candidate most successful? Especially when we acknowledge that face transplant is typically not a life-saving procedure. And as I mentioned in this little box here, ideally the timing and evaluation for face transplant would allow plenty of time between the inciting event and transplant consideration to give time to grieve the loss, come to grips with the injury, and receive treatment and stabilization of pertinent mental health comorbidities. And so when we shift to looking after transplant, I've kind of separated this into short-term psychiatric considerations and more long-term psychiatric considerations. So starting with short-term, right after the surgery and in the recovery time frame, there's a lot of components in learning how to simply function again, such as relearning how to eat, addressing food avoidance behaviors, and even fear responses around eating certain types of food, especially with some of their first meals while in the hospital after transplant. From that same token, while they are in the hospital recovering, we hold a pretty high value in ensuring privacy for these patients. And so we had a special security task force to ensure that the media is not coming in trying to see the patient, that staff are not entering the room or the chart inappropriately. And we had very clear guidelines on who would be providing the actual patient care for these patients in the hospital. We also placed great value in ensuring that we had a clear, controlled, and obvious time frame for the patient to see their face for the first time. We engaged in fairly intensive psychotherapy while in the hospital in this preparatory phase, enough to where we actually had all of the reflective surfaces covered in the hospital room until the team, and more importantly, the patient, was ready to have the formal face reveal. This would include walking through things and processing. What do we need to do to be ready to see our new face? How can we best address and approach the different comorbidities that may be at play? And how can we help with your new body image and your new identity? Which leads us to a really special event that we had for our two face transplant recipients that we called their formal face reveal. As I said previously, they have not been able to see any reflective surfaces during their recovery time after face transplant. And we formally have a moment to where a very select group of people is allowed to come and be there when the patient sees himself in the mirror for the first time. And though you can't see the psychiatrist in the left photo, you can see my red tie at the top of the right photo. It's a really touching moment for both the staff and the patient and their family members. And I will say this. One of the most common questions that I get from patients, family members, and even audience members after a presentation like this revolves around whether or not the patient looks like the donor. The short answer is no. There's a lot of factors that form your facial structure, and these are very individualized. And not all of these factors are transplanted over. However, there may be some subtle similarities. In this context, when the wife of the donor met our first face transplant recipient after the surgery, she actually commented on this fact, citing similarities in facial hair distribution, which you can actually tell from these photos, and a mole on his nose, which unfortunately is a bit harder to see in these photos. But otherwise, these are two quite unique looking individuals. Moving on to more long-term psychiatric considerations. Obviously, there's going to be a PTSD risk in these patients. Commonly, the inciting events that cause the need for a transplant is a traumatic experience in itself. And we know from the literature around facial injuries causing disfigurement that the PTSD risk is influenced by the level of stress prior to the injury, the severity of the pain subsequent to that injury, and the amount of social supports and psychiatric comorbidities that are at play. Now, we do not have the PTSD estimates from our face transplant recipients, but in general, disfiguring physical facial trauma has an estimated rate of PTSD at about 23% 1 year after the injury. And just like in the short term, there are still long-term privacy concerns, especially in the healthcare setting. It may be wise to place a higher level of privacy on the patient's individual charts. Similarly, we acknowledge that these rare cases are great for trainees to see, but there is a concept of patients having trainee overload and having story fatigue, especially when establishing care for a new complaint. Like, every time I go to the emergency department or urgent care, I have to sit through the healthcare team's reaction when they hear that I've had a face transplant as part of my medical history. And this leads to a common phenomenon that we know called the spotlight phenomenon, right? As well as the life adjustments that are commonly seen in patients who become somewhat low-level celebrities. Having a high level of media attention, popularity, and being under the focus of the public eye brings about a higher level of vigilance, discomfort, and privacy concerns. And it's already difficult for individuals to shift their life from everyday Joe to being a celebrity in the general population. This is even more important, and it's even harder to shift to this public status when the reason that you're shifting to your low-level celebrity status is from a major traumatic event. On that note, there's a lot of focus on post-traumatic growth and resiliency. And I'm proud to say that both of our face transplant recipients are quite involved in advocacy efforts and regularly speak at conferences for mental health awareness and suicide prevention. And I want to end this presentation with one final quote from the book Face in the Mirror about our first face transplant recipient. It really drives home this point that face transplants are not life-saving, but they certainly are life-giving. After his face transplant, he attended a Minnesota Wild hockey game. As he sat in the arena eating popcorn with thousands of other fans around him, no one gawked at him. No one leaned over to whisper a comment to a companion. Everyone was focused on the game, and he was relieved to do that too. He felt like another face in the crowd. It was glorious. I don't have to live in fear anymore. I can go out and be myself. And I want to thank everyone for taking the time to listen to my presentation. I'm happy to answer questions via email if you'd like. And I'll introduce the next speaker, Dr. Shruti Mutalik, who will be presenting on the very interesting topic of tracheal transplant.
Hi, everyone. Thank you so much for tuning in. I am Shruti Mutalik. I'm one of the CL and transplant psychiatrists working at the Icahn School of Medicine at Mount Sinai in New York City. Thank you so much, Erin and David, for your wonderful presentations. I'm going to be talking about the psychosocial perspective on tracheal transplant. I have nothing to disclose. And my goals and objectives for today, by the end of my 15 to 17-minute talk, I hope to leave you with a sense of the role that consultation liaison psychiatry played in the care of the then sole recipient of tracheal transplant. I hope to be able to explore the role that palliative care can play in these rare organ transplants, and also highlight some of the lessons and the challenges learned. I want to start with immense gratitude towards this individual, who at the time was the sole recipient of the tracheal transplant, both for making this medical milestone possible and also for being so tremendously generous with her story, and for granting us the consent and permission to share aspects of the psychological part of her story and the support that we provided, starting with the ACLP conference back in 2022, where we had a poster about our involvement. And this is an article in the New York Times. So the first single segment tracheal transplant was performed in 2021, January 13th, and it was an 18-hour-long procedure, which, of course, as one can imagine, required a very large team of about 50 individuals. It was led by Dr. Eric Jendon at Mount Sinai Hospital in New York City. It was a one-of-a-kind, pioneering procedure and was a viable option for long segment tracheal defects. And one thing unique about it was that it used a deceased donor, not scaffolding, not a synthetic trachea, not stem cells. And long segment tracheal damage can occur either due to congenital reasons, such as birth defects, or acquired reasons, which could be airway disease, burns, tumors, damage from procedures such as intubations or bronchoscopies, etc. As one can imagine, these defects are associated with a lot of quality of life concerns. That can be dyspnea, dyspneic exertion, hoarseness of voice and vocal changes, and defects that are less than around 5 to 6 centimeters in length are typically reconstructed using end-to-end anastomosis, but defects that are longer than around 6 centimeters in length, they've historically been a challenge. Palliative stenting has been used in order to restore the airway lumen. But for a long time, there has been the scientific dogma that because of the unique segmental blood supply of the tracheoesophageal complex, microvascular transplantation is not possible. And at the time that we saw this particular case and were involved in their care, that was the sole recipient of the tracheal transplant. I did see that in the literature since then, there was a review in 2024 which showed 14 cases of tracheal transplant, of which 2 were aborted, 1 had an operative mortality, and 4 had complications. But there have since been, so since 2021, there have been cases of tracheal transplant that have been successful, but the literature still uses the term embryonic phase. It's still considered a very experimental procedure. This is from the Mount Sinai website, our center criteria for tracheal transplant, a male or female in the age range of 18 and 75, a tracheal defect that's longer than 4 centimeters due to multiple reasons that we talked about, and someone that's able to, of course, provide written informed consent and is willing to participate in all the procedures for evaluation and examination. As one can imagine, is standard for transplants. There is a recipient review committee meeting where presumably all the clearances have to be placed and the patient has to be approved for listing there. And of course, has to be a compatible blood type and cross-match with the donor. There are no standardized psychosocial criteria since this is such an experimental new procedure. But drawing from the psychosocial criteria that we use for most transplants, here are the domains that were considered prior to the psychosocial clearance of the first tracheal transplant. Informed consent, of course, which entails this embedded sort of capacity assessment, understanding of risks, expectations, of course, adherence to medications and protocols and appointments. Of course, some elements, which we'll talk about a little bit more, of advanced care planning. Well, what are the hopes from the procedure if things don't pan out quite that way? What would be the next step? What would be the alternatives considered? Of course, we are looking for psychiatric stability, so there's a psychiatric needs assessment. Of course, we are assessing for active substance use disorders, and depending on the organ and the center, there are certain criteria. This was not relevant specifically to our case, but drawing from the lung transplant literature, certainly abstinence from smoking or vaping is something that can be extrapolated into tracheal transplant. Then the presence and functionality of a support system. So this is, of course, a picture that is public open access in the media, showing the jubilation in the initial phases, the initial aftermath of the transplant. Speaking about the case more specifically, so this was a 57-year-old former social worker who had a history of asthma, and she was intubated back in 2014 quite emergently, and it was a protracted intubation. Eventually, she required a tracheostomy that was permanent in 2015. And all this resulted in scarring and stenosis that was about 8 centimeters in length. And there were attempts at conventional tracheal reconstruction, whether it's end-to-end anastomosis, cartilage grafts, and they did not really work. And as one can imagine, with the tracheostomy, there were these quality of life limitations. There were a lot of mucus plugs that used to form. There was difficulty getting out of the house without suctioning. And of course, there was the risk that in the future, there would be progression of airway disease and tracheal collapse. And so the patient actually underwent a procedure right from 2018 of consultation and clearances and evaluations, lots of conversations regarding the tracheal transplant, and then eventually was waitlisted for about 8 months while a suitable donor was identified. In terms of the choice of the donor, as one can imagine, the donor was somebody that they had to rule out any tracheal malignancy, tracheostomy, the presence of central venous access. Of course, this was a deceased donor. And we're grateful, of course, to the benevolence of deceased donors and living donors that make these milestones possible, make these procedures possible. But one of the things that I also found interesting was that they specifically were looking for a male donor because they were going to do, as they did, fluorescent in situ hybridization in order to track the presence and reepithelialization and replacement of donor cells by recipient cells. And so having a male donor with the Y chromosome basically made this tracking much easier. So in terms of the involvement of psychiatry, we were consulted for suicidal ideation in this 57-year-old former social worker who was basically admitted for a planned bronchoscopy with closure of the tracheal stoma, and because of technical difficulties, this was aborted. And the patient basically said that she would be better off dead. She was very disappointed, very frustrated that this happened. And even though this was called suicidal ideation, she actually had no suicidal ideation intent or plan. She basically said that she was just very disappointed at what had happened and wanted to pursue palliative care. She had actually been seeing palliative care off and on prior to the transplant. She said that her quality of life had actually been pretty good up until 2014, and then following the intubation, there were lots of limitations with mucus plugs and dyspnea. And then following the transplant for about 6 months, she actually felt really healthy and really great. But then also the stoma posed limitations in terms of what she was able to do. So our intervention was, we of course provided support at bedside. We recommended strongly a palliative care consult, and actually the palliative care consult was supremely helpful in being able to bridge the gap between her expectations and her frustrations and what the team was reasonably able to do and what they were comfortable doing, which was actually scheduling a stoma closure. And this transpired following that admission. The patient had been discharged to family, and she was quite satisfied with that surgery. She was also engaged in psychotherapy. In the subsequent year, she did suffer complications and unfortunately died in July of 2023. In terms of palliative care involvement, of course, during this acute crisis when psychiatry was involved, we advocated for the involvement of palliative care. And then also towards the end of her life, there was a goals of care meeting. But more broadly, in terms of the role of palliative care in transplant, as one can imagine, in patients that are declined or delisted for transplant, there's a very clear role for palliative care that's very obvious and intuitive. But also, transplant itself can cause a lot of suffering. And there is a role for palliative care in patients who are post-transplant and also in those who have end-stage organ disease and that are awaiting listing or are listed for transplant. However, when one looks at the literature of palliative care and transplant, there are very limited studies and there's a lot of room for improvement. This is a retrospective cohort study between 2018 and 2020 at a liver transplant center in the United States. And this is patients who were declined or delisted, and only 27% of the declined candidates were actually referred to palliative care. There was a cross-sectional survey of candidates in a lung transplant program in the United States in 2020, those awaiting lung transplant or undergoing lung transplant. And out of these 111 participants, only 6.4% actually reported seeing a palliative care specialist, and about 48.2% did not know what a palliative care specialist was. Less than 10% of patients who have end-stage organ disease, and as we know, that goes with so many quality of life limitations, but only less than 10% of these patients actually are involved in discussions of advanced care planning. So there's a lot of room for improvement in this arena. This is a scoping review from 2025 for palliative care and solid organ transplant candidates across 4 different organs. And the main findings are that the involvement, 35% of those cases were really end-of-life conversations, and the vast majority of palliative care involvement was really focused on symptom management right before death, which we posit is really, really very unfortunate and a missed opportunity for optimal clinical care. So envisioning a role for psychiatry, I think that pioneering transplants, these one-of-a-kind transplants, really navigate uncharted territory. There's so much uncertainty, so many unknowns, so many quality of life challenges and potential for complications. A lot of this, as David mentioned, the spotlight effect, right? It's taking place in a setting of limited privacy in a public arena, and psychiatry can really play a pivotal role in not only supporting these patients, but also in advocating for quality of life examination and discussions throughout the course of these transplants. We can, of course, help in navigating identity transitions, and we can really advocate for palliative care services, which, as we know, can have so many barriers that may be at the patient level, but also more broadly at the systemic level, the institutional level or physician level. I think that as we saw in our patient, she wasn't really saying, I don't want to live. She was saying, I don't want to live this way. She had always expressed this desire to be able to swim in the ocean, to be able to get out of the house, dance with her grandchild. And while those options were on the table and she was able to do them or imagine them, she remained hopeful and optimistic. But when they were not really on the table, that's when she wanted to transition to less extraordinary measures. So some of the lessons learned: integrate the involvement of psychiatry longitudinally to build a relationship and support the patient every step of the way, but also advocate for palliative care every step of the way. There are also ethical questions that arise about, there's limited data with these one-of-a-kind transplants, and we're extrapolating from other transplants, but what is the threshold in terms of patient selection and patient stability? What is the level of risk that we're able to tolerate? And of course, this is a medical breakthrough, so there are medical lessons learned, many of them, but of course, one key one was that re-epithelialization or chimerism and chimerism were a few of the factors that helped prevent the rejection of this allograft. So Thank you so much. And I have a lot of people to thank, certainly the recipient and the donor and the team that made this experimental procedure, this pioneering breakthrough possible. My fellow Shirley Torres, who was involved in the care of this patient and took excellent care of this patient, as well as Omar, Daniel, and the surgeon, Dr. Jendon. And I also want to thank the wonderful team here doing really amazing work, Erin, David, and Ambika, and of course the ACLP and the Transplant SIG for making this collaboration possible, and Lindsay and Christine here. With that, of course, feel free to reach out to me with any questions or anything that you want to talk about or discuss. And I would like to invite Ambika Yadav, my wonderful colleague here at Mount Sinai, who's going to be talking to us about hand transplants. Thank you so much.
Hello all. Thank you, Dr. Mutalik. For the last part of this presentation, I'm going to be talking about hand transplantation. This is one of the more common VCAs. In terms of disclosures, I have no disclosures. Learning objectives for this presentation include a brief history of hand transplantation, learning common indications for hand transplantation, understanding the psychosocial and ethical considerations in hand transplant recipients, as well as a brief discussion of the outcomes in recipients of hand transplant. Initially, when learning about VCAs, I thought of, whether it was hand transplant or face transplant, I thought of this is something that's probably going to be done 100 years in the future. So it was shocking to learn that with the first kidney transplant that was done in 1954, the first hand transplant was actually performed in 1964, 10 years after the first kidney transplant. It was done in Ecuador. Unfortunately, the transplant had to be explanted after 3 weeks. However, with the discovery of calcineurin inhibitors in the 1980s, this was revisited. And the first more modern era hand transplant was performed in France in 1998. At the time, due to issues in the patient with psychologically adjusting to the new limb, which led to them stop their immunosuppressive medications as well as participating in physical therapy, that transplant failed. In the United States, the first successful hand transplant was conducted in 1999. Until 2009, there were 53 successful transplants worldwide, and present day, there's just about under 300. The data is a little bit variable, and we'll talk about why that is a little bit further. This actually happens to be the hand transplant recipient from 1999, also happens to be the longest surviving recipient of a successful hand transplant, just going on about 25 years at this point. In talking about hand transplants worldwide, this data is taken from 2024. This reports about 179 hand transplants worldwide, with India actually leading with 73 hand transplants. One of these show a hand transplant recipient 9 years after the first transplant in India, which was conducted in 2016. And also the other picture is Brendan Morocco, who was a hand transplant recipient, a bilateral hand transplant recipient, the first of its kind at Johns Hopkins. In talking about types of hand transplants, there's bilateral, as the name suggests, replacing both hands, versus unilateral, and then partial. Partial is actually more a cadaveric simulation, has not been done in a patient, but it is being explored. There are certain selection criteria when considering upper extremity transplantation, and it's actually quite shocking that the American Society for Reconstructive Transplantation was founded in 2008. So a lot of the transplants that we covered earlier were actually done prior to 2008. With the emergence of hand transplants, a need to lay more consistent guidelines about hand transplants was identified. So the basic clinical criteria for hand transplant established by the ASRT include amputation or irreversible functional loss, followed by a comprehensive medical history and physical exam, one performed by a hand surgeon, as well as a surgical treatment plan, in addition to a comprehensive medical history and physical exam that's conducted by a transplant physician and surgeon. With this, also a comprehensive social and psychological exam, which is where we come in. Usually, patients are over 18 years of age. Since these guidelines, however, there have been some pediatric hand transplants. Also, the amputation or loss of function should be accompanied by medical or functional complications that demonstrate an impact on loss of quality of life. Comorbid etiologies must be ruled out, and then there are certain contraindications laid for by the ASRT for hand transplantations, including unilateral amputees with no evidence of significant functional, social, financial impairment as a result of their amputation. And we'll talk about how this contraindication has impacted the trend of hand transplantations after 2008. Congenital amputees as well as pediatric traumatic amputees. When we talk about, and this was something that was covered by my colleagues in talking about VCAs in general, but one is, yes, VCAs are not necessarily life-saving. Another layer in hand transplant is there is an alternative. Obviously, there are differences in, the functional outcomes of the alternative, but there is the possibility of a prosthesis after an amputation. So here we compare a prosthesis versus a hand transplant. So when it comes to prosthesis, obviously, it's something that's well established. It is something that's covered by insurance. Typically with prosthesis, the fitting can take place relatively early after, the injury. And in terms of gaining control over the prosthesis, especially if it's a below elbow amputee, it's pretty intuitive and can be learned with adequate rehabilitation setting. Also, there's no additional surgery or lifelong medications when it comes to prosthesis. The cons of a prosthesis, however, are even though they are covered by insurance, there's a lot of costs associated with prosthesis. They're expensive. They're not durable. A lot of people find them to be very heavy. A literature review from 2007 actually showed that 1 out of 5 individuals actually reject their prosthesis. The other downside of having a prosthesis is there is no sensory information coming from a prosthesis. So it's very difficult to perform precise motor tests, and visual control is mandatory in those situations. Also, it's really hard to carry body hygiene or grooming with a prosthesis. In comes transplant. So the pros of having a transplant, one, aesthetically, it obviously looks like a natural part of your body as opposed to a prosthesis. It also enables a sense of touch, which is very unique, which is not possible with the prosthesis. Lends to a sense of body integrity, ownership, and wholesomeness. Although functional outcomes, when given the small numbers, they're not reported as consistently, different groups have shown excellent and long-lasting results. So in terms of functionality, including being able to master more fine motor activity, as well as body hygiene and grooming, transplant probably has better outcomes. The downsides of a transplant are the risks of lifelong immunosuppression, rejection. One of the reviews showed 24 graft losses were reported due to patient death in that review. And in the first year, one of the studies shows 85% rate of acute rejection. That being said, it can mostly be managed, but that is a pretty high rate of acute rejection. In addition, the post-op rehab is pretty intensive. There's 1 to 2 years of very intensive post-op rehab. And lastly, it is considered experimental and it's not covered by insurance. We'll talk about some of the ethical, financial, and policy considerations in hand transplant. So, this is something that my colleagues already covered, and and it does more broadly apply to VCAs, but with the additional layer of prosthesis being an option for people with upper extremity amputation. So, in talking about risks versus benefits, the biggest argument that a lot of providers have against a hand transplant is the risk of immunosuppression, given that a hand transplant isn't life-saving, isn't necessary to sustain life. The risk of immunosuppression, one could argue, is actually possibly, or at least theoretically, decreasing life expectancy, which is something that a lot of providers have a hard time contending with. The value of a hand transplantation can only be determined based on the quality of life derived from the procedure rather than the quantity of life added after a life-sustaining transplant. On the flip side, supporters of hand transplantation stress that given the rights of the recipient, autonomy should be the deciding factor in deciding whether to transplant a hand. And they argue that it is impossible for people who have two hands to understand the potential benefit that hand transplantation can have for an individual. Interestingly enough, when we're talking about risks versus benefits or beneficence versus non-maleficence and then paternalism, from a provider perspective, there was a survey conducted to understand provider attitudes towards hand transplant, and understandably, this is from 2009, so attitudes have definitely changed. But that revealed that bilateral below elbow amputation was the most accepted indication for hand transplantation, and by hand surgeons of the American Society, 78% agreed that a bilateral below elbow below elbow transplant is acceptable. But only 32% also supported hand transplantation in people with unilateral amputations. And surprisingly, a majority, 69% of the respondents in the survey, assessed hand transplantation as a high-risk endeavor and were either against it altogether, so 45%, and 31% were undecided. That's a majority of hand surgeons not sure about whether a hand transplant even makes sense. Financial considerations. So there was a study that talked about the increment cost usefulness ratio of a hand transplant. And just for some context, for a kidney transplant, the increment cost usefulness ratio, which is the amount of financial resource required to impact the quality adjusted life years, for a kidney transplant, it's somewhere about $50,000. When you think of what that means, the higher the IC you are, the less feasible in terms of cost efficiency, the less feasible a transplant is considered. For a unilateral hand transplant, that number is at about $500,000. So based off of this study, hand transplants were considered financially not feasible. In talking about psychosocial considerations for hand transplants, so again, things that were covered in the previous presentations, given the low numbers, we don't have clear guidelines of, how to evaluate or a specific validated tool to validate VCA transplants. But in drawing from solid organ transplants, one of the domains obviously is insight and readiness. That is willingness to accept the risk, given that it is not necessarily life-saving. Social support, which is, again, very similar to solid organ transplants. The recovery is, one can argue, a lot more intensive and a lot more challenging compared to a lot of solid organ transplants. With regards to psychiatric comorbidity and substance use disorder, in addition to, when we talk about solid organ transplants, we're concerned about ability to adhere with care in terms of primary affective or psychotic disorders. We're concerned about the ability to take care of oneself, or even worst case scenario, suicidal ideation. And with substance use disorders and talking about certain organs, for example, with the liver, we're concerned about direct damage to an organ. So outside of a psychiatric comorbidity or substance use disorder impacting self-care, even within hand transplant, one could argue that certain psychiatric comorbidities and substance use disorders could actually contribute to the etiology that led to the amputation itself. For example, there have been situations where patients who've had schizophrenia have not been caring for themselves, have ended up out in the cold, having a frostbite, not having that been addressed, developing cellulitis, gangrene, leading to amputation, and then requiring a transplant, versus somebody having alcohol use disorder and being out in the cold because of alcohol intoxication, ending up in the same situation. Adherence obviously remains important, just like solid organ transplants and VCA. The other VCA transplants mentioned. A unique thing that, again, was mentioned by my colleagues is a matter of identity in talking about VCA transplants and hand transplants. So usually solid organ transplants aren't something that a patient can constantly visually be aware of. So specifically talking about hand transplants, one of the things that patients oftentimes have to contend with is being aware that the hand that they're looking at is not their own hand. And when we go back and talking about the history of the hand transplant and talking about the first modern era hand transplant that was done in France, that was actually the reason that led to rejection of the transplant eventually and the failure because the patient psychologically dissociated because of not necessarily identifying the hand as their own. Another aspect of identity is, people realizing that not necessarily identifying that hand as theirs, and then their feelings surrounding that hand touching other parts of their body. And finally, this is more, in the legal realm, it has been studied that even as long as after 40 months after a hand transplant, fingerprints don't change. So theoretically, in modern day and age where identity theft is such a big deal with, with potential legal histories, there needs to be a lot of emphasis on protecting the recipient's identity and also the challenge of effectively taking on another person's identity with fingerprints. So that's an important consideration in hand transplant. So what's really important with the data and talking about hand transplants and VCAs in general is that the Organ Procurement and Transplantation Network, as well as the United Network of Organ Sharing, did not oversee VCAs until July 3rd, 2014. So this has been a major milestone with data collection, which lends a lot of uniformity to the data coming to us after 2014. The final rule standardized the definition of VCA as a covered human organ and also ensured that all centers follow the same rules and similar parameters for implementation. In talking about some recent trends in hand transplant, as we talked about before, the American Society for Reconstruction and Transplantation was officially founded in 2008. The OPTN and UNOS covered VCAs beginning 2014 and laid down more, specific guidelines for reporting, which actually led to a slight decline in the number of annual hand transplants. That, in addition to several other factors, including, funded related challenges, as well as if you can remember in 2008 when the ASRT came up with the guideline of switching of saying that bilateral hand transplants made sense, but unilateral there were more restrictions on unilateral hand transplants. So as you can see, this is as of 2016, there was an uptick in bilateral hand transplants after those guidelines came out. In talking about outcomes with hand transplants, one of the biggest, and this is something we talked about when we were comparing transplant versus prosthesis, the motor and sensory function following a hand transplant in a lot of ways is superior to prosthesis, especially when it comes to fine motor skills and sensation. So in one registry, all transplant recipients developed protective sensibility against pain. 90% regained tactile sensibility and 82% achieved discriminative fine sensibility. And the greatest benefit that people reported, which is 75% of the recipients, they reported an improvement in quality of life. In terms of graft losses, this is as of 2011, there were 5 graft losses out of the 57 transplants, and one of them was related to compliance issues. The biggest risk with hand transplants is obviously the risk of immunosuppressive therapy with opportunistic infections, metabolic disorders such as diabetes or Cushing's, and malignancies. Acute rejection, while pretty common, is actually something that can be managed. So while 85% in one study there were 85% of the recipients underwent acute rejection in the first year, but none of those organs were lost in that period. This is some data that came to us after the OPTN and UNOS made some standardized reporting guidelines. So this is a little bit more detailed information with follow-up. So this covers the disabilities of arms and shoulder and hand scores in 10 transplant recipients. Not all of them, a few of them did not have serial reports, but most of them, as you can see, are showing a decline in their DASH, except for one patient. With regards to psychosocial outcomes, we don't have as much robust data, but this is N is equal to 1, so obviously there are limitations to this, but this covers several psychosocial metrics in one patient who received a bilateral hand transplant surrounding self-esteem, depression, social desirability, quality of life, social functioning, and as you can see, most of those parameters stayed rather stable. And, one would ask, well, if they're staying stable, what are we really addressing? So there were some theories as to why. I think on one hand, those measures staying stable is a relatively safe outcome. What we don't want is those things to actually decline. But one of the theories as to why they were staying relatively stable was one in, selecting a candidate. We are extremely selective and we're picking somebody who usually already is fairly well adjusted and is doing well from a psychological perspective. The other theory was these are self-reported scales. So there was an argument that possibly a person would report falsely higher scores in order to seem like a good transplant candidate. I think the final limitation, obviously, is this was looking at one patient. Finally, I would like to end with some patient testimonials regarding hand transplant. A bilateral hand transplant recipient stated, "I opened my eyes and noticed my new hands swaddled and splinted. I thought, like a father seeing his newborn. Those are the most beautiful hands I've ever seen. Immediately, they felt like mine. My mental map and the territory of my body realigned in an instant. This moment was wholly opposite the trauma 3 years earlier of emerging from surgery without arms. Now I felt healed." And I think, this really highlights that while we have such small number of patients that, we have such little data to go on, like my colleagues also highlighted, it's not necessarily the life-saving nature of a transplant, but also life-giving nature of VCA transplants that make it something worth exploring despite all of the ethical considerations that we've talked about. And ultimately, and these are my references, ultimately, I think what we've learned through hearing my colleagues speak and in preparing this presentation is this is an emerging field. There's not many of these transplants that have been done, and there's several challenging ethical and psychosocial considerations. And a lot more research is needed as more and more cases emerge. Thank you so much.